You see, there he is. Dr. Ben Park is our next speaker. He's the Benjamin F. Byrd Jr. Chair of Oncology. He's the director at the Vanderbilt-Ingram Cancer Center and professor of medicine at Vanderbilt University Medical Center. Welcome, Dr. Park. So good of you to join us today.
Thanks, Sherry. As everyone knows, I go by Ben or Dr. Ben for those who can't not.
I know you don't want to be known as your dad.
Exactly. Dr. Park is my dad. All right, let me see if I can share my entire screen, which it looks like. Can you all see that?
Yep, I see Zoom.
Awesome. And then
There you go.
hopefully you don't hear my dog whining in the background. And
Oh, it's okay.
hopefully that means he won't poop on the floor during
Oh,
this. He has been known to do that.
oh goodness.
I saw all these cool laser pointer options now. I'm going to try blue.
Oh.
Awesome. All right. Doesn't really show as well. Maybe I'll try green. Oh, that's better. Okay. Should I go ahead, Sherry? I'm gonna take that as a yes. All right.
Yes,
Uh,
yes, sorry.
I love puns, so bad puns, the worse the better. So the title of my talk is Circulating Tumor DNA in Early Stage Breast Cancer. Breast friends don't keep secrets, meaning that we, I believe now, can figure out with a high degree of certainty who still has breast cancer and who doesn't for certain subtypes of breast cancer. I'm excited to share these results. These are my disclosures. So I usually give an overview because everyone has varying degrees of knowledge and background in breast cancer. So for those of you who already know all this stuff, forgive me and I apologize. But I'm going to talk first about a little bit about what we call cell-free DNA and the technologies that we use to detect this analyte. And then also importantly, what are goals of therapy? They're very different for early stage breast cancer versus metastatic disease. And I'm sure many of you know this, but I want to also kind of put behind this the rationale and the principles of how and why we treat early stage disease with various therapies like chemotherapy and hormone therapy, and then what we've been trying to do in our lab and in our field for the last 10 to 15 years to figure out better ways to individualize therapies. And that's using, again, this thing called circulating tumor DNA or ctDNA. Hopefully there'll be plenty of time for questions. Again, I think this audience doesn't need any introduction to all of these facts, but in the United States, there's going to be now 300 cases diagnosed every year. But the majority of women and men with breast cancer will be cured. But even so, with that denominator, there's still 40,000 patients that are going to die from breast cancer every year, just in this country alone. So I often tell my patients when I first meet them, the goals of therapy for early stage breast cancer is to cure. That's stage 1, 2, and 3. And the more tumor volume you have, the higher your stage number and the less likelihood of cure. But stage 3 breast cancer, depending on the subtype, still is curable, and in some subtypes, very curable. Metastatic disease, however, for the most part, is not curable. I say for the most part because we're actually finding we can cure some subtypes of metastatic disease nowadays. We don't know exactly who or why gets these great responses. It's usually in the HER2 population, but it is potentially curable. And there'll probably be some data coming out in the next year or two about that. However, in lieu of that, there are many more patients, men and women, that we've now turned metastatic breast cancer into a chronic disease. So even though we can't cure it, we can control it. And that's kind of akin to what insulin has done for diabetes. For many patients with proper glucose control, exercise, diet, etc., more patients with diabetes end up dying with their disease rather than from it. And so for those patients with metastatic disease that we cannot cure, that really is the secondary goal. So again, just to bullet point it, metastatic, prolonged life, treat symptoms, adjuvant therapy. That's what we do in the curative paradigm. Again, that's what I do as a medical oncologist, what Dr. Dizon does. We give systemic therapies after local therapies, usually surgery or surgery and radiation. And what we're trying to do is get rid of microscopic metastatic disease that we can improve upon cure rates. And every year, more than 150,000 or probably now 160,000 or more patients in the United States are candidates for these additional breast cancer therapies. So how do we actually know that these adjuvant systemic therapies work? As I just said, metastatic disease is not curable. How we define that is both clinically and radiographically when we can see at least a centimeter of tumor. And the reason it's not curable is because breast cancer and all cancers really are diseases of DNA gone bad, meaning that the DNA gets mutated, changed, etc. And it continues to do that throughout its kind of lifespan and progeny of daughter cells. Normal cells, when they divide, the DNA is identical to one another, they're identical sibs. In cancer, that doesn't happen. There's genetic instability so that one cancer cell divides into two, they're slightly different, 2 to 4, etc. So by the time we see metastatic disease, there's already over 1 billion different cells of cancer in the body. And we don't have enough therapies right now to get rid of all of them. On the other hand, there's this concept of, again, adjuvant systemic therapies that came about in the 1980s and 1990s. And the idea was, hey, we can remove the tumor, but maybe if there's still microscopic disease, and the higher the stage, the higher the likelihood because you have more tumor with higher stage. So if you're stage 3, less likely to be cured, and you're more likely to have these cells running around in the body. Let's give patients additional systemic therapies because they don't have macroscopic metastatic disease. And rationally, you have to think about, well, that means that if we flood the body with chemo, perhaps they haven't undergone enough cell divisions yet to develop resistance to everything. So that's really what we're doing now is we tested these hypotheses in the 80s and 90s, and sure enough, studies like this is an overview in a journal Lancet from 2005. If you have one group of, let's say, 100 patients with triple negative breast cancer, and after surgery, you gave that group chemotherapy, and we give always more than one because, again, we got to attack all the different cancer cells and all the different resistance mechanisms. And the control group, which was very closely matched for age, stage, and type of breast cancer, just got placebo after surgery. Then at 5 years, you can see that the recurrence rate is 38% or 38.8% in the control group. But what happens in the chemotherapy group, it goes down by about 13% to 25.5. These types of studies take years to decades to read out because your only readout is who's recurrent and who's not. They require large, randomized, multi-institutional trials that are the highest level of statistical evidence. But a consequence of this is that we end up now over-treating. We know as a group, treating this group with chemo is the right thing to do. But if you look at this example of something that's now defunct, but called Adjuvant Online, if you were to just look at this line, then 63.1% would be alive at 10 years. A third died from their cancer, and 4.3 died from other causes. With chemotherapy, the absolute benefit is about 13%. And that's that yellow bar. But the problem with this approach is we don't know who is actually cured. So we make decisions based on individuals, on populations, and not on individuals. And so when I see it for the patient for the first time for adjuvant chemotherapy, I don't know if that patient is here in the green, in the yellow, or the red, but our paradigm, our mandates say that patient is at high enough risk, we have to give that patient chemotherapy. And that leads to over-treatment and in some ways under-treatment because chemo isn't going to be effective in about half the patients that need it. And that's really been the biggest conundrum and crappy paradigm that I've been trying to shift for the last 10 to 15 years. So we've always imagined that we could do this using a blood test and specifically looking at something called circulating tumor DNA, which I'll get into in the next slide. But you can imagine a scenario that if someone has breast cancer, and then after the breast cancer, while they're diagnosed, they should actually be positive for the blood marker. And then if they get surgery and they're cured, the 60-some% in that prior example, they shouldn't have anything in their blood marker. On the other hand, for the 30-some% that are not cured, they're going to be positive for that blood marker. And importantly, if this blood marker is quantitative, we can give these additional therapies and monitor really in real time to see whether or not there's in fact an effect of the cancer going away. Now, how do we do that? We're actually looking at DNA from the cancer cells. As I just told you, cancer is a disease of DNA gone bad. It has tons of mutations, and these mutations are actually what make the cancer cells different from normal cells. That allows us from a therapeutic angle to target just cancer cells because the mutations are different, so we target those mutations. But it also is a great diagnostic tool because only the cancer cells should have these mutations. And so many, many years ago now, my former mentor and boss, Byrd at Johns Hopkins, really championed this idea of using what we call circulating cell-free DNA and then also circulating tumor DNA as a diagnostic blood test. And so just to put some definition behind it, all of our cells in our body shed naked, free-floating DNA into the circulation. We don't think that this has a purpose. I've been known to call it cellular poop because we think it's just a waste product. And cell-free DNA from normal cells comprises the vast majority of cell-free DNA in our bodies. If a patient has cancer, their cell-free DNA from the cancer is also shed into the circulation. But remember what I said is that the DNA from cancer cells is different. It's mutant. And so that's called circulating tumor DNA. Another reason this is a great biomarker is because the half-life of plasma DNA or cell-free DNA is very, very short, on the order of 1 to 2 hours. And so if you give a drug and if it's working, you should see the circulating tumor DNA go down. But as I mentioned, the vast majority of cell-free DNA is from normal cells. Even in patients with stage 4 metastatic disease, it's hard to detect the kind of needles in the haystack is how we look at it. But we've gotten new technologies over the last 15 years that allow us to do this. This was one of our first earliest studies in patients looking at early stage breast cancer patients using a technology called droplet digital PCR. This is when I'm still at Johns Hopkins, and it was a very small study, 29 patients. All we were doing was looking to see if we could detect circulating tumor DNA before and after in patients with newly diagnosed breast cancer. I'm not going to belabor this because it's already been published over 10 years ago. The quick answer was yes. Again, we use a now not very used technology that allowed us to quickly query for mutations in early stage breast cancer. But what we were enthused about was that we could detect 14 to 15 mutations in these patients preoperatively. That was 93.3% sensitivity. All patients that didn't have mutation, this specific mutation in the breast cancer, we didn't detect any false positives. And then post-operatively, we actually were able to detect PIK3CA mutations. Again, that's a common mutation in breast cancer that we helped isolate or discover. And so that was really encouraging to us that we could really pick up microscopic disease. Subsequently, there's been a lot of work in the field. I like to point out this one. This is from a former fellow of mine who's now pretty famous on her own, in fact, very famous in her own right in this field in breast cancer, Heather Parsons. She actually just moved from Dana-Farber and is heading the breast program now at Fred Hutch. But she had this study when she was at Dana-Farber looking at late recurrences in ER positive, we now call it hormone receptor positive, HER2 negative disease. And these are patients who had been on endocrine therapies for 5 to 10 years. And she actually demonstrated that, because we know that there's a lot of late recurrences now for patients who have this type of breast cancer, that they were able to detect 8 out of 83 patients had ctDNA, again, after all their endocrine therapy, and that 6 of those 83 developed metastatic recurrence with time. 1 developed a local regional recurrence, and there's 1 or 2 that had not still yet had a clinical recurrence, but we suspect that they probably will. What about neoadjuvant chemotherapy? Many of you probably know this, but many times for certain subtypes of breast cancer, we'll give chemotherapy up front to shrink the tumor. And then that also plays a double role in getting rid of, hopefully, all the cancer cells that could be floating around in the body. We originally started doing neoadjuvant chemotherapy or chemotherapy before surgery to provide the option of lumpectomy and better margins for certain patients. But we quickly discovered that depending on the subtype, specifically triple-negative breast cancer and HER2-positive patients, 50 to 60% of those patients would get what's called a pathologic complete response, or a PCR. And that when we looked back, patients with PCR did better than patients who did not have PCR, as a kind of a general rule. And so this became a surrogate biomarker, if you will, for assessing new therapies that led to faster FDA approvals. There are some drugs here that are examples of that. And then in addition to that, we also have discovered that if patients don't get a pathologic complete response, then they're at higher risk, although not all patients. And so those patients nowadays are getting different therapies or additional therapies after the surgery. So that's, in my view, kind of like this. You could get chemotherapy up front, and then we had this idea that what if you were ctDNA negative? Were you in fact cured? And so you wouldn't even need surgery. On the other hand, if you were not cured and you were ctDNA positive, you would go for surgery and then assess again with this liquid biopsy and see if you need additional systemic therapy. So in my mind, in my grand scheme, pie in the sky, idea, we could use blood to inform every clinical decision. And so we wouldn't necessarily have to do everything the way we're currently doing it now, but we could almost think about breast cancer therapy in modules. Do you need surgery? Do you need chemo? Do you need radiation? Take a blood test and see if you're cured or not. And so that led to this study called Pathologic Response Evaluation and Detection in Circulating Tumor DNA, or PREDICT DNA. It was done through the Translational Breast Cancer Research Consortium. The study number is 040. It was also done with or in conjunction with Johns Hopkins Clinical Research Network when I was there. So this actually opened 10 years ago. It was a very simple study where we took stage 2, stage 3 breast cancer patients and got tissue and blood all along the way. And the original idea, the primary objective was if you were positive for blood before you started your chemo, and then you cleared it, did that predict for pathologic complete response? With the idea that we can, again, offer a patient, man or woman, a non-surgical option to save the breast. On the other hand, it had to have a low enough false negative rate, meaning that if you were ctDNA negative, the correlation that you had pathologic complete response had to be at least 90%. That's the statistics that we built in. The more impactful endpoints were these blood draws, because this was really going to be our attempt to say for the triple negative breast cancer cohort, because those are the patients that recur more quickly and more frequently, whether or not we could use ctDNA to say a patient was highly likely to be cured or highly likely not to be cured. So this is kind of the statistics. I'm not going to go into all of this. This is the assay we use. And again, in the last 10 to 15 years, a lot has been done on the technology side. So this is an assay that's called Personalis. We partnered with them. It can get down to 1 to 3, what we call parts per million. The prior assay was about 1 in 10,000. So you can think of this as 1 in a million or 2 orders of magnitude more sensitive. But they take the patient's tumor. This is what we call a tumor-informed ctDNA assay. They find all these mutations and they'll pick anywhere from 200 to 1,800 to design an individual personal assay for every patient. And then we'll use those markers to look at all subsequent blood draws. This was the study. Again, we accrued and finished our accrual in 2018. This is the concert diagram. This is the patient characteristics. I'm not going to go over that because it's not that exciting. So what was initially really disappointing was we did not meet our primary endpoint. Even though every patient that had PCR was in fact ctDNA negative, it turns out these numbers worked out to completely to be 100. Our negative predictive value wasn't good enough, meaning that there were ctDNA negative patients, 40 of them right here, that were in fact non-PCR. They had residual disease at the time of surgery. So that was unacceptably high in terms of the false negative rate, and we did not meet that primary endpoint, which was disappointing. But then we kind of discovered something maybe even better. All right, so this is actually pathologic complete response in our triple negative breast cancer cohort, and it kind of looks like you might expect. Patients who have pathologic complete response do really, really well. Those that do not don't do as well. And many things can splay this curve, the bottom curve, into different things. We actually use the strictest definition of pathologic complete response. There's something called in situ disease or stage 0 breast cancer. Most clinical trials would put that up with pathologic complete response because there's non-invasive disease. But remember, our kind of shtick was that we were going to try to give patients a no surgery option. So leaving in situ disease would not have been acceptable. So we made in situ disease non-path-CR, and that probably brought these two curves closer than they should be, which is also why our p-value was not statistically significant. Again, that's just pathologic complete response. When we looked at the subset of this group that we had bloods for throughout the whole study, because there was some attrition, we wanted to make sure that it looked the same, and you can tell they look identical, also was not statistically significant. Here's where it got really interesting. So even though we didn't meet our primary endpoint, when we looked at the ctDNA cohorts separately, negative versus positive, we found that ctDNA was in fact a better prognostic indicator than even pathologic complete response. And strikingly, remember what I told you, there were a number of ctDNA negative patients who were non-path CR, and they look identical. So if you take this gray curve and then splay it into patients who had pathologic complete response or didn't, they're identical. So in fact, ctDNA negativity becomes, in my mind, a superior marker than pathologic complete response. And obviously, if you have ctDNA positivity, you end up not doing as well. There is this tail end of the curve and a couple of patients here that had recurrence. And I don't have the data to show you right now, but a little bit of a teaser. So this is what we presented at ASCO. The other data that we have that's being submitted is even better than this after we did some more analysis. But essentially to say these are now patients post-surgery where we got the blood draw. I think you can see here what we call persistently negative. These are patients who were negative before surgery, but after neoadjuvant chemotherapy, and then negative after surgery up to 1 year. And those patients do extremely well. Essentially, they're going to be cured. And then if we look at patients who are positive at any point in the pathway, whether it was preoperatively and postoperatively, which is persistently positive, or they converted from negative pre-op to positive, they end up not doing well. What's very, very interesting to me, when we looked at the data of this tail end of the curve, some people might say, that's a false positive. You got all these patients that are doing well that were ctDNA positive. It turns out, and again, it's not in this curve represented separately, those are the patients that went from positive to negative. So again, in those patients, surgery and maybe additional chemotherapies still actually mattered and converted them into a much better prognostic category. Now, you might think this is a one study. It was and still is, I believe, the first prospective study that had statistics built in from the very beginning. We call that pre-specified secondary or primary endpoints, which gives it a much bigger kind of gravitas in the statistical world. And it was the only one using this ultrasensitive test. The name of the study, again, is ctDNA. Simultaneously, this was presented also at ASCO this past summer. The company also had done a study very similar in France called Scandari. And you can see that the results are almost identical. And to both our groups, that was very, very gratifying and satisfying because I think this is real. These are all triple negative breast cancer patients. And I think essentially what we've really done is now converted this not into a prognostic marker, but a diagnostic one. And I'm telling everyone what I think we should really be thinking about these blood tests is they're not markers of, hey, where are you going to be at 10 years or 5 years? They're actually now more like mini CAT scans, meaning that they can tell us with very high accuracy, at least with the triple negative breast cancer cohort, whether or not patients have residual disease. So it doesn't matter what therapy they get. It doesn't matter where we take it. It just matters where it's positive or negative. And if it's positive at that time, that's going to be bad. And if it's negative at that time, that's going to be good. But if it's positive and we do something about it, like in those patients that converted, like surgery or other chemos, maybe we can actually cure more patients. So that has now led to the second PREDICT trial called PREDICT DNA to Cured. There's the acronym that took me a while to come up with. What we're going to do is try to both de-escalate therapies as well as escalate. Right now, for stage 2 and 3 triple negative breast cancer patients, they get this very, very long and oftentimes toxic chemotherapy and immunotherapy regimen. We're going to give them the first half of it, but if they're ctDNA negative, we're going to take them right to surgery. If they're not, they're going to get the traditional second half of this neoadjuvant regimen and then go to surgery. But we're going to be taking ctDNA measurements, liquid biopsy measurements throughout the way. And what will happen is that what we're anticipating is there won't be many patients once they're negative that convert to positive. But if they do, we're going to have an arm where we're going to try to actually take these patients, give them new novel therapies. We're working with a lot of drug companies, as well as maybe therapies that are already approved for metastatic disease, but are just getting approved for early stage disease, including a drug called Trodelvy or sacituzumab. So this opens up the opportunity to cure more patients, not based upon population studies and percentages, but based upon individual blood tests that tell us whether or not patients are cured or not cured. So in conclusion, hopefully I've convinced you that ctDNA detection can really change the paradigm and rationale of how we're going to treat breast and other cancers going forward for early stage disease. It really and truly will allow for individualized precision medicine. patients will get exactly what they need, but not too little or not too much. However, we still need to do a lot of clinical trials to actually get to that level where we can say this confidently, hey, treating is actually going to lead to more cures. Again, going back to this study, that's a big component. We're going to de-escalate this group, right? Because if they're ctDNA negative, we're going to hopefully spare them the second half of the chemotherapy. But this is the group at highest risk, the so-called persistently positive. That's the group that definitely needs newer and better therapies. And we hope to actually improve upon the recurrence rate by continuing to treat until they're ctDNA negative. That'll take about 10 years to complete if we're lucky. And so what do we do now? These tests are available because the FDA, you don't need to prove what we call clinical utility to get a diagnostic marker to market. You need to actually prove clinical validity. And all that means is, does your test do what you say it does? And so that's where we are right now with ctDNA testing for the most part. Our newer generation of tests, as I mentioned, is very, very sensitive. The specificity is practically 100%, but the sensitivity still leaves room because there are still some false negatives. And what we don't know, as I iterated already, does acting on this actually lead to better outcomes? So what do? Patients are asking for these tests. They're coming to us. Many patients and providers don't really understand the subtle nuances of all these different tests, how to use them, should we use them, et cetera. And so we're in a data-free zone right now. And I've actually just decided to be an early adopter, one, because I know this field, I have a lot of experience. We helped create it many, many years ago when I was at Johns Hopkins. And in 10 years, by the time we get the results of these tests, you know, I'll be 68 and looking at the barrel of retirement or down the barrel of retirement. And so I've thought about this a lot. How many patients could we possibly help, or could I possibly help during that 10-year time? And so what I try to do when patients come to me and they've either had the test done by someone else or they want the test is go through several parameters. It almost becomes like genetic counseling is now. What do you do with the positive result? Try to always have a plan. The first thing I always think about is you got to scan them, because there's going to be a subset of patients that are positive, and when you scan them, they have overt clinical disease. Do we have a clinical trial available? Could they get additional therapies that are already approved that they haven't received yet, et cetera? Need to make sure that we eliminate and reduce financial toxicity for the patients. Many of these companies will eat the cost, but they will still try to bill insurance. And we need to be very, very, very cognizant of the fact that we don't want our patients to get back billed and have thousands, if not tens of thousands of dollars of debt because of these tests. I also explain what is the difference between a tumor-informed assay, that's the assay we use, where you need the cancer tissue to look for the mutations and mistakes and then look for those mistakes in the blood. And what are those limitations? I had a patient who had what I call a first-gen test done, and she wanted the second-gen test, and we ordered it, but it turns out her first-gen test exhausted the tissue. So she can't get any further testing. And so I told my patients with the second-gen test, you know, there could be a third-gen test coming out in the future, and we may exhaust it on this second-gen test. So you have to understand that's a possibility. It's exhaustible tissue. I counsel patients not to underestimate the anxiety from these tests. I've had enough experience with these now that this can really be angst-provoking. And I think most people in the audience could really understand and acknowledge that you're waiting on a test that's going to tell you that you may have cancer. And we don't necessarily know if we're going to be able to treat that and make it go away. So I always, again, try to have a plan that if it's negative, we'll usually think about repeating it in 3, 6, 12 months. If it's positive, again, I practice getting staging scans to make sure there's no overt metastatic disease, and then to have some plan of therapy that we can actually do something with. So far, again, this is all brand new. I've ordered about 30 tests, which isn't quite that many. 4 patients have actually declined testing after I've had the discussion that I showed on the preceding slide. So I use that as, I think, an objective measure that I'm trying to present the pros and cons of these tests objectively. 4 patients have had positive results so far. One had 8,000 parts per million, and I was very concerned that with that level, she's probably already going to have metastatic disease, and sure enough, she did. She had liver metastases, and this was very soon after starting endocrine therapies, despite having clinical stage 1 disease. Unfortunately, she had rapidly progressing disease and passed away just a few weeks ago. I've had another patient that already had metastatic disease, but she's one of these extreme responders who has been doing okay on and off hormone therapies and does not have evidence of disease of her cancer anywhere. So that's an instance where I decided, okay, maybe using ctDNA can help us since it can detect micrometastatic disease. And sure enough, she actually still does have a low level of disease, and we're following that. But so far, it's stayed stable. It has gone up a little bit, and we've just changed around her endocrine therapy a little bit. So again, this may help us almost like glucose monitoring for insulin and diabetes using my former analogy. Maybe this is kind of our glucometer, if you will, to follow and help manage metastatic disease. And then also I had one more recently who had 200 parts per million. I was really worried that that patient was going to actually have metastatic disease. This is triple negative breast cancer. But it turns out when we scanned her, she has a local recurrence. So this is potentially still curable. And we're going to start treatment on her just this week. So she's been really thankful and excited because we probably would not have found this local recurrence with our current guidelines. We just wait until something happens. And that probably would have been metastatic disease. So we need to, I feel that for this particular patient, this is going to actually matter. And the last one is probably my most dramatic example. Was a young patient, 3 parts per million, which is hardly anything. She had a history of triple positive disease, so ER/PR positive, HER2 positive. She is a young woman in her 40s, has 2 young daughters. She got the traditional neoadjuvant therapies, did not have PCR, received Kadcyla or TDM1 afterwards. And then after 6 months after she had completed her Kadcyla, we performed the first test and she had this 3 parts per million. So the first thing we did was stage, make sure there was no overt metastatic disease, and there was none. This included also an MRI of her brain. And so a drug we don't tend to use much in HER2 positive disease, even though it's approved for a year after Herceptin, is neratinib. Now, it has a lot of diarrhea, it has some other side effects, and that's why many of us don't use it, because the percentage of benefit is quite small after a year of Herceptin. Again, most of those patients are going to be cured. But we repeated this test after 6 months, and you can see this here. This is her 3 parts per million, and this is where she's at now. So neratinib is approved for a year in this early adjuvant setting, where that will be for her in about 4 or 5 more months. And we're going to repeat this. We'll stop the drug and hope that this is in fact eradicated and gone. So my conclusion for this part is that, Voltaire once said, perfect is the enemy of good. And I kind of extend that perfect is the enemy of good enough. Some may not agree this is good enough. And I do agree for the negatives. We can't deny standard of care right now outside of a clinical trial. And many people are saying, are we opening a Pandora's box? But I always like to counter that with, if you read the story of Pandora's box, the last thing in that box is hope. And I firmly believe that there is really high hope that circulating tumor DNA is going to help us save more patient lives. And with that, I just want to acknowledge my lab and all the people who are currently in it, all my collaborators, both industry and academic, and especially our patients, as well as the foundations and government funds that have supported this endeavor over the past 15 years. And I think that is it.
Wow, thank you. I'm so glad that you have hope, because we have hope that you're going to continue working far beyond those 10 years. I do have some questions for you that have come
Okay.
in. Actually, 2 of them are from someone who I recently connected with you, Michelle Jakonski.
Uh-huh.
She is asking if this test is close to being able to help a man initially in the gray area, post-surgery and post-chemo, help doctors decide if they should also do radiation.
Yeah, we're not there yet. As I was mentioning earlier, because there's still a false negative, and there probably always will be still a false negative with these tests, denying standard of care therapies, which are potentially curative, we just can't do that right now. So that is definitely something I am not doing. But in a clinical trial, we have a little bit more leeway when we know that the percentage of patients that are benefiting from, all the therapies is leading to a lot more overtreatment. And so that's why the trial that I designed, in fact, there's a similar trial ongoing right now. It's not using circulating tumor DNA, but it's called the Scarlet trial, where they're giving the first half of that regimen, just like we are, and then they're going to go to surgery and see whether or not pathologic complete response is there. And if they are, they're not going to get the second half. But if they're not, they are going to get it after surgery. They'll get the second half of that regimen. So it's kind of similar, but a little bit different because they're just using pathologic complete response. We're using blood markers, which I think are an advantage because we now can get those results fairly quickly and we don't have to wait for surgery to make that assessment.
Mm, okay. And her second question was, I thought I heard the first speaker, it was Dr. Cordosa, say the first line treatment for breast cancer in men is to start with endocrine therapy instead of surgery or chemo. This was a bit confusing to me. I thought it was reversed usually. Question mark.
Yeah, for breast cancer early stage for men, usually it's still surgery up front. It depends on the type of breast cancer they have. I wasn't there to listen to Dr. Perosa's talk, but she might have been saying for metastatic disease, which
Yes.
we do actually use endocrine therapy with now what's called the CDK4/6 inhibitor. Sometimes now we're adding a third drug to that, depending on the mutational profile. And for metastatic patients, unless there is a reason locally, meaning that, there's symptoms from the breast or the axilla, we don't do surgery for metastatic disease since that surgery can have complications and it doesn't lead to better outcomes. Now, there is a lot of debate in what we call de novo stage 4 disease. That means a patient presents, man or woman, with metastatic disease. Does taking out the primary tumor afford a benefit? There have been some studies that say yes, a lot of studies that have said no. We've tried to do prospective randomized studies. They've been impossible to complete because nobody wants to go on the control arm of not getting surgery. So we're left with not great data in that zone. And most of us, I think, have adopted the policy of, just like Dr. Cardoza said, start with, if this is de novo, not a recurrence, but if you have de novo metastatic disease and you presented with metastatic disease, start with systemic therapy like endocrine therapy and a CDK4/6 inhibitor and monitor. If that patient has a great response, then consider maybe doing surgery. So that's kind of, again, everyone does it a little bit differently. There's no set rules or guidelines because we don't have great data.
Thank you. As research evolves, how close are we to a future where ctDNA helps prevent late-stage recurrence or reduces the uncertainty survivors live with today?
Yeah, that's the exciting part. I think for what I just showed for triple negative breast cancer, at least goes a long way for that. We did not have ER positive, HER2 negative disease in our cohort. But I have seen data, and again, some of what I showed was from Dr. Parsons to address that. That curve showed that in 10% of her patients, 8 of 80 something, they could pick it up. And in fact, that predicted or prognosticated for recurrence, in some cases, months to years ahead of time. So we really are going to get there, I think, in the next 5 to 10 years. And maybe for triple negative breast cancer, we're already there. But what we don't know, again, is if you're positive, can we do something about that? That's where we really need to try to come together, get trials done, and in the interim, as I showed in my example, start trying to do something. Because my kind of issue right now is if you have a positive ctDNA test in this setting, like I just showed, the specificity of these tumor-informed tests are such that that's not fake, it's not a false positive, it's real. And that means that patient has cancer still in their body that's likely to come back, especially if it's triple negative breast cancer. And so for me, it's almost unethical not to try to do something because I know what's going to happen. We have now curves, which I can't show now because it's not published yet, but those patients postoperatively, 1 year after surgery in triple negative breast cancer, they all recurred. Not a single one did not. And that to me, again, is the opportunity that we can try to help those patients until we get all these studies done
That's
or
great.
open. That's the
That's
other thing.
great.
It's
Yeah.
hard to convince anyone to pay for these studies
No,
because it's challenging.
I know. It's difficult.
I
We
don't mean to
actually,
be cynical, Sherry, but you have to think about what I'm trying to do is instead of enrolling 100 patients,
Yes.
we're only going to roll 10, the 10 that are at risk, right? And then
Yep.
going forward, if that gets approved, then only 10 patients will be getting therapy, not 100. So from a drug company standpoint and a business standpoint, you kind of don't want that, right?
Yeah.
So that's where
Yeah.
we're kind of at a crossroads right now is, okay, well, who's going to pay for studies that are going to lead to less money for the drug companies? It's not going to be the drug companies.
Uh, we just have to keep looking under rocks.
Yeah.
If you could leave every breast cancer patient with one message about hope, honesty, and the future of precision medicine, what would you want them to remember?
We have new and exciting discoveries happening every day. But part and parcel of this is in order to really get the hope and engender that feeling, you also have to be your own advocate and make sure you're getting every test that you possibly can that makes sense. Not ones that are like, from mom and pop garage shop. But I'm talking about coming to a big academic medical center like Vanderbilt-Ingram Cancer Center and making sure that every available test, I see this every day, Sherry, where people didn't get everything. And for the most part, that's okay because finding the alterations that um, could be life-saving tend to be not as common. But I just had this happen 2 or 3 weeks ago where a patient that came from California, moved here, transferred here, metastatic disease, has gone through the ringer and really probably on her last therapy, never had testing done of the tumor or again, liquid biopsies. And I set one off and I'm blown away by this because it's so rare. She has something called an NTRK fusion, which we have really powerful drugs for. So I was super excited to tell her this. I'm not sure she grasps the gravity or the rarity of this finding, but this potentially could be life-saving for her. And so
Yeah.
that's what I mean. Details matter. That's going to be our new campaign at Vanderbilt. Details matter. And it's really true. You need to make sure not to leave any stone unturned.
Yeah, you have to keep asking.
Yep.
I always said I was the kid that asked the question why,
Yeah.
and why and what else. Um, ctDNA can reveal traces of cancer that don't appear on scans and tests. How does this technology help uncover hidden disease before it becomes a bigger problem?
Well, that's kind of what we've shown. What we don't know is does treating it lead to better outcomes? I'm convinced it will for some patients, but that's exactly right. We're looking for micrometastatic disease because at that level, the patient is still potentially curable. And that's, in my slide deck, traditionally in the past, those are the patients in the red bar, meaning that they got chemo, but they didn't benefit.
Hmm.
So now we got to figure out, is there other drugs, other therapeutic modalities that we can use to cure those patients? That's what the basis of my trial is going to be. At the same time, as I mentioned, I'm doing this on select patients where there could be a drug or is a drug, like that triple positive breast cancer patient who's now getting neratinib and cleared her ctDNA from positive to negative. That to me means we have actually done some good. And
You've
my
hit
hope is that she
something.
is now cured where before she wouldn't have been.
Yeah. I have one more here. Patients often find comfort in simple, less invasive testing. How is a circulating tumor DNA blood test different from traditional scans or biopsies? And why is that exciting for the future of cancer care?
It's a great question. They're different because they're not going to replace scans and biopsies. I just want to make that crystal clear. What
Mhm.
I hope they evolve into is exactly what I was saying earlier with the analogy of diabetes and a glucometer. You have to think of ctDNA in the future as a glucometer that we can measure, does someone have cancer? And if they do, still remaining in the body, even though we can't see it by scans, can we actually make that go away by giving new novel therapies or even therapies we currently have, but that patient has not seen yet? So that's really where it is. It's not a replacement, it's an additional tool. And I refer to it in my talk as almost think of it now as a microscopic CT scan, where it's looking at the whole body, just like a CT scan would. And if you have
Mhm.
disease, it'll be positive. If you don't have it, it'll be negative. But just like a CT scan, there are false negatives and sometimes false positives, at least in the CT world. That's where I think we have to start changing our thinking and evolving our thinking that these are diagnostic tools, not markers.
Hmm. We have more tools in the toolbox these days. That's a
Exactly.
good thing. Much of your presentation focused on triple negative breast cancer and HER2 disease. I was diagnosed with HR positive HER2 negative male breast cancer 6 years ago with no recurrence so far. However, I've had numerous symptoms over the years and numerous scans to rule out recurrence. What are the pros and cons of ctDNA tests for someone in my situation? How predictive would positive or negative results be for my type of breast cancer?
Yeah, so again, it depends one on the technique and technology used. Using a ultra-sensitive tumor-informed assay like we have would actually be probably 100% specific. But we know hormone receptor positive, HER2 negative disease, which is the majority of not just male, but also female breast cancers, tend to shed less ctDNA because they're less actively dividing cells. That said, the example I showed from my former mentee, Dr. Parsons, demonstrated those are all patients who are HR positive, HER2 negative. You can still pick it up. And if it's positive, you could potentially do something about it. So that's where I think we still have some room to do to improve the sensitivity. But everything I talked about will eventually go out to, I think, all solid tumors with some exceptions. But definitely HR positive, HER2 negative breast cancers are being studied, have been studied, and there already are some data on that.
What would you suggest someone do that isn't being seen at Vanderbilt and perhaps not at a big academic center if they're being told that this is something that they couldn't do or isn't available to them? What's your suggestion?
Well, they're not, whoever's telling them that is not saying it incorrectly. As I said before, these really are um, not ready for prime time in the sense that we don't have clinical utility data, as I keep harping on. That said, the horse is out of the barn. Patients are getting them. They're FDA approved, so you can get them. Insurance companies will even pay them because they are now approved. And so I think that that's where, rather than try to fight an upstream battle, I'm trying to actually leverage the fact that patients are getting them and trying to help. Because what I think is a worse outcome is patients will get these. Doctors don't understand these tests. They don't know what to do with it. Patients don't understand these tests. They don't know what to do with it. So it's our job as a field to educate and to try to come up with sensible algorithms that would actually allow us to do something meaningful with this. It's going to be far from perfect, but if we don't do it, I don't know who else will. And I worry that people are going to get really bad information and bad advice and, go off the deep end. So my colleagues and I are working on a white paper. This is through the Translational Breast Cancer Research Consortium to address this very issue of what do we tell patients, what do we tell providers, and then hopefully maybe even funnel them or channel them into clinical trials that are available at our institutions. There are about 16 or so institutions that are part of the TBCRC, because that's really where we need help. We need to partner with patients as well as local providers to get these answers. But I am very fearful that patients are going to, for example, I often tell patients, one of my patients asked me this, and now I tell everyone ahead of time, if you get a new breast cancer, or if you get a colon cancer or a lung cancer, the blood tests will not pick it up. It is exquisitely fine-tuned only to the original breast cancer. That's, again, the whole nature of tumor informed. But these are
Mhm.
things that a lot of people aren't thinking about or even know because they don't understand the nature of the test. So this is where, again, the Pandora's box analogy, we've opened it,
Yeah,
but there is still hope at the bottom.
thank you. Will this test always be based off the initial tumor sample, or does it use current blood samples in later testing?
Well, so it's both. When you first get it, it takes the blood at the time where they're making the assay. But once and that can take 6 to 8 weeks. So that's also part of the thinking that we have to be cognizant about when we're designing trials. But once you've actually gotten the sequencing done and gotten the first blood test reported out, the company has that data. So the next subsequent blood tests, and that's the value of this, is that you can continue to serially repeat this. Those are much faster because they're not going to resequence everything. They know the original tumor, and so they're going to keep looking for those same markers in subsequent blood tests. And that's the beauty of it, that you can now do this in a couple weeks after you've done the initial tumor informed part. There are
Mhm.
tests that are non-tumor informed, and those are much more challenging because so those would potentially pick up a new breast cancer, oral colon cancer, or lung cancer, but they're not as specific and they're not as sensitive in their current iterations.
Okay. I think I have one more for you. For a patient worried about recurrence, which most are, what reassurance, I'm sorry, or clarity can ctDNA provide about whether their cancer is truly gone or if it could come back and what
Yeah,
care would be
that's
needed?
exactly, why we started out in this business 15 years ago. I will tell you though, there's never going to be a perfect in biology. We had some patients that were negative that did recur. So again, the false negatives are still there. Although for one of them, or maybe two, I question whether or not it's a new breast cancer, quite frankly, because it
Mhm.
was so far out of 5 years for triple negative. And that is really, I think, the driver of that is that we need to understand there's never going to be a perfect in biology. That said, I'll give you another example of a patient of mine. She had triple negative breast cancer. She's been living the last almost 5 years, living in uncertainty and at times fear. And when this test came about, she actually was scared to do it. She was almost at 5 years, anyways. And then her husband really wanted it done. And they talked about it long and hard, and they decided to do it. I could tell, I'm not sure he really wanted to do it. I'm not sure she really wanted to do it.
You want to know, but you don't want to know. Yeah.
Exactly. But we're all sitting on pins and needles for weeks waiting for the results, and they were negative. And there wasn't a dry eye in the house when I
Oh,
presented this to her. And she's actually come on. There's going to be a series called, well, there is a series called Empowered with Meg Ryan. She's going to be on it with me and someone else. I think it's supposed to come out this month. And she talks about how before the test, she always just felt like, could this come back? Could this come back? She went to her son's wedding and said, I couldn't enjoy my son's wedding because I just kept thinking, am I ever going to see my grandchildren? Will I be alive? And she said what the test has done for her, even though it's not perfect, it has changed the scales. And it is more than likely that she is cured, especially now being at 5 years. And I told her, your chance of getting killed by a car accident are probably way higher than breast cancer coming back at this point. So
wow.
that is, I think,
That's
the power
amazing.
where you
Yeah.
have now data to really show this. And so for her, this has been game changing. So it's a long-winded answer to that question, but I hope it demonstrates some of the subtle, nuanced power that these tests can help us in what to inform our patients.
That's amazing. You're actually giving somebody a little bit more hope and a little bit more breath
Yes,
because there's always that sitting on your shoulder and that's a
exactly.
horrible feeling. Well, I think I've hit the end of my questions, but as always, Ben, thank you so much. We appreciate you and everything you do
Thank you.
and wonderful presentation.
All right. Take care.
Thanks.
Bye bye.
Bye-bye.